Okay, thank you. I would like to start by thanking the organizing committee for inviting me here. It's a very great pleasure, and I'm looking forward to the next couple of days. I'll focus my presentation on biomechanics of the hip joint during a maximal instep soccer kick, and how that relates to the risk of groin injury. And please note that when we talk about biomechanics, we often use these terms on the right side, as opposed to these more linear terms. We often have these rotations around a joint, so we talk about angular velocity, angular acceleration, and so on, because we have these movements about joints. So in relation to groin injury, adductor-related pains are most common. Second most common is pain related to the iliopsoas, and third most common to the abdominals. This is recent data by Per Hølmich and Christian Thorborg. And most of that is related to overuse injuries. It's more common than traumatic injuries. So I'll focus my presentation on these muscles. So from a biomechanical perspective, what can cause overload of muscle and connective tissue? There are three main factors. The first is high force that pulls on the muscle and connective tissue. Second is a stretched muscle position. And the first is a fast stretch of the muscle and connective tissue. So let's take a closer look at those. The first one with high force. When does that occur? This is a classical force-velocity relationship. So if you do a fast concentric contraction, you can develop very much force. If you do it slowly, we can develop more force, and we're even stronger during the eccentric contraction. And I want to show you today through the biomechanical analysis that during the soccer kick, we have high eccentric forces acting. So the next two factors, stretch position and a fast stretch. If we stretch a muscle, then we also stretch the connective tissue, the tendons. Then tension increases in the connective tissue up to some point where it will eventually break. Doesn't happen so often. But if you stretch it fast, then it looks like this. Even at the same length, the tension in the connective tissue will be higher, because the connective tissue has viscoelastic properties. So when you stretch it fast, tension develops faster. And that's also happening during a soccer kick, and I'll show you that today also. So biomechanical analysis. Some of the first work in this field was simple 2D analysis in the sagittal plane, showing that the kick occurs in a proximal to distal segmental motion, initiating with the hip peaking in the velocity, and then the knee, and then the ankle, and so on, like a whip movement. But this doesn't take into account movements in the other planes, like abduction, adduction, rotation of the leg, and so on. So that's why we need three-dimensional analysis. And the basic principle of this is to place markers on the body, on different anatomical landmarks, and then have cameras around the person here in a reference frame, and then sample all this in a computer. Then we can recreate the motion in the computer and calculate positions, angular velocities, angular accelerations. And from that, we can also, if you know the mass of the segments, we can calculate the moment of inertia, and then we can calculate the moment of force acting on the joints. In this presentation, I'll focus on the hip joint. So if we put a skeleton on our stickman, it can look something like this during the instep soccer kick, from a side view and a front view. Then we can divide the kick into different phases. Mostly in the literature, it's been analyzed from the toe lifts from the ground of the kicking leg, and then until we strike the ball. So that's 0 to 100% of the kick. And then we have these three phases. First, when the toe lifts the ground, then this initiates the backswing, where the hip extends, so the leg goes back like this until maximal hip extension, which ends the backswing phase, which then initiates the leg cocking phase, where the hip starts to flex and the knee starts to flex. The leg cocking phase ends when the knee is maximally flexed. This then initiates the last phase, which is the acceleration phase, which lasts until we strike the ball. So, and this occurs only in a quarter of a second. This takes the longest 160 milliseconds from this study. It can vary a little depending on the study, and 40 milliseconds and 60 milliseconds. So that's the three phases that I'll talk about today also. Then be aware when we talk about this moment of forces acting on the joints, then it's net moment of forces. So it can be a combination of muscle activity from the muscles that we think makes movement, but also the antagonist muscles breaking the movement. It can be gravity pulling on the leg, and it can be reaction forces. When we hit the ground with the supporting leg, it makes reaction forces acting also on the hip joint. And it can be what's in the literature been called motion-dependent moments. So, for example, if we flex our hip at the same time, if we flex our knee, that affects the hip joint, and the other way around. And if we move our upper body during the kick, it also affects the movement of the thigh through the hip joint, because the segments are connected through the joints. So there's this intersegmental connection that also affects the net moment of force. So this is a study from 2002 that did 3D motion analysis, and this is one of the early studies. They actually only had 2 cameras instead of 8 in the more recent studies. But they calculated the movements around the hip, the velocities and the moment of forces. So let's take a look at that. First, this is in the plane of flexion and extension around the hip joint. The solid bars here shows velocity, and this one shows moment of force. So when the values are negative, it means towards extension, and when they're positive, towards flexion. So first, here the values are negatives, meaning that the hip is extending, so the leg is going back. That's a backswing phase, until here, where we start the leg cocking phase. But notice in this phase that the moment of force is going in the opposite direction. The moment of force is actually going towards flexion. That's why the velocity here is decreasing, because it's breaking the movement. So what does this mean? If it was only the muscles that was doing this, then it would surely mean eccentric work for the muscles breaking the movement. But we actually don't know that from this study, because it's a net moment of force. So it can also be motion-dependent moment of force that's decreasing this velocity here. Let's take a look at the adduction. So the same thing is going on here. At least between approximately 15 and 60% of the kick, we have a negative value here, meaning that the leg is actually moving towards abduction. So the leg is moving outward relative to the hip. But the moment of force is positive, so it's against adduction. So this could mean that we have some eccentric work here during the backswing phase. So we can say at least during the backswing phase, there's an extension and abduction of the leg. There's also actually a small internal rotation. It wasn't shown on these graphs. But it causes lengthening of the hip adductor and flexor muscles. And if they're active, that does mean they're working eccentrically. But we need EMG to measure that, if they're actually working during these lengthening phases. So it could be these muscles, the peroneus, the adductors, the adductor longus, iliopsoas. So EMG, we can measure EMG by surface EMG on most muscles in the body. For example, adductor longus here, the external obliques. But then if we really want to measure the iliopsoas, we have to use needle EMG to get, because it's covered by the other muscles here. So we have to stick in a needle to measure that. And then we can find roughly a good relationship between EMG and force. So the higher EMG we measure, the higher the force the muscle develops. But then what what people often tend to forget is that at any given level of EMG, the force will be lower if it's a concentric contraction than eccentric contraction. So we can't just compare EMG between different contraction modes. We have to take into account also the type of contraction. This is a study that did that. They did the 3D motion analysis together with measurements of EMG. And this is what they found for the iliacus and the hip, for the adductor longus. During these 3 phases of the kick, the backswing, the leg cocking, and the acceleration. There was a fairly high EMG activity in both muscles during all the kick. The activity for the iliacus was highest during the leg cocking phase, and for the adductor muscles during the acceleration phase. But for all muscles, the activity, you can see here it's above 60% of maximal activity. That's a high activity. So just by looking at this, we'd probably guess that the highest forces would be here and here. But it's not so, because here we have mainly eccentric work. The muscle is lengthening, and here the muscle is shortening during the acceleration phase. So the forces can actually be much higher here than here, because this is a fast concentric contraction. We're not able to develop very much force during a fast concentric contraction, but we certainly are during an eccentric contraction. So we have the high forces acting here. So that could be where the main risks are for injury related to these muscles. I tried to find something on the abdominal muscle activity during the soccer kick, but it was not possible for me to find anything about that. I did a PubMed search using these terms, and no results showed up that was related to 3D motion analysis together with EMG activity of the abdominals. But you would suspect that they work in similar ways, or they work together with the hip adductors and the hip flexors, because we have the segmental motion and this tension arc when we kick. So, but we don't have any EMG results on that. So I can't tell you how much they activated. But definitely some research is needed in this area. So this is a third study. So in addition to EMG and 3D motion analysis, they also calculated the actual change in length of the adductor muscles. So you might wonder, how can you do that? They actually did it by reading in the literature where these muscles attach to the pelvis and to the femur. And by doing that, then we have a triangle, and then we can use trigonometry to calculate at any given joint position. We can then calculate, because we know the angles here, then we can calculate the length of the adductor muscle. So when we have it over time and during the kick, we can also calculate the velocity of lengthening and shortening. So that's what they did in this study. Let's take a look at it. So this is a change in length. It's actually the velocity of the muscle. Positive meaning that it's lengthening, negative meaning that it's shortening. So here, the adductor muscle, this is during the kick, the backswing, the leg cocking, and the acceleration phase. With the peak hip extension occurring 40% into the kick at about 23 degrees hip extension. Here we can see that the adductor longus muscle is lengthening all the way up to here, to about 66% of the time of the kick. And what's interesting here is that we have the maximal velocity here, a quite high lengthening velocity, and then we continue to stretch the muscle all the way up to here. So what happens when you stretch the muscle and the tendon fast? Well, the tendons have viscoelastic properties, so the tension will increase, and then we stretch it even further. So I think here it's probably where we have the greatest risk for injury, at least to the connective tissue. And then we have the peak hip abduction. It's occurring quite late, at about 80% it's into the kick, a bit after the leg cocking phase. And then we have the adductor muscles. They can work both as adductors and hip flexors. That's why they don't just peak out here, because the flexors start to flex the hip, and then they shorten, but here they still lengthen, so they end somewhere in between before they get to 0 and then shortens. But the important thing is here that we have eccentric work here at a high speed, and then we continue to stretch the muscle and the tendon. So based on these 3 studies, we can say that the adductor muscles work eccentrically at high velocity during the backswing phase, and at a very stretched position during the leg cocking phase, and at high force because we had the high EMG activity combined with the eccentric force during both phases here. And some of the other studies here suggest that it's probably somewhat similar for the iliopsoas muscle. So just to sum it up, during the backswing and leg cocking phases, we have these high eccentric forces due to the high EMG, the fast stretching, and we have the stretch position because we both extend and abduct the hip joint, and we have the fast stretch due to these fast movements. The soccer kick occurs in a quarter of a second, and we could see that the peak rate of stretch occurred during the backswing phase. So together that can increase the risk of groin injury, at least from a biomechanical perspective. So solutions, what could be the solutions to this? Obviously, I don't have the answers to that. I think it depends much on the specific type of groin injury. At least if it's related to the muscles and tendons, I think it could be worth trying eccentric training. Not just low intensity, but high intensity eccentric training. It's been used a lot in other types of musculoskeletal injuries. So what happens? Well, at least the muscle and connective tissue gets stronger. That's one good thing. But it's also interesting that the length tension relationship right shifts. So at any given length during the first lengthening phase of contraction, there'll be a lower tension in the tendons because of this right shift of the length tension curve. May also mean that we are not as strong during these phases. So it may be a compromise between performance and prevention of injuries. I know eccentric training has also been in some of the intervention studies, and time is flying. So let's just finish off with a suggestion for future research, because I think much of the research has been focused on the individual capacity, how strong is the individual, or flexibility, range of motion, and so on. The exposure measures has been much related to the number of training hours or match play. But I think we need some on-field biomechanics to measure how much hip extension, how much hip abduction occurs during actual play and during training. So one suggestion could be to put accelerometers on the different segments during training and during play. It's possible to use 3D accelerometers to do this, but it would take, of course, some work to develop this. And there are also wireless EMG that can measure muscle activity during all sorts of activities. So that could be one way forward in the more epidemiological field in this with soccer and groin injuries. So. Okay, so I want to finish by saying thank you for your attention. So